Welcome to Imperfect Heart, a place for you to join me, Jeff Holden, in conversations, discussions, and dialogue about our hearts and the impact myocardial bridges have on them. We'll talk with healthcare professionals, those in related fields that support our condition, and others just like us with stories of their myocardial bridge experiences. It's my intention for this content to inform, educate, entertain, and even motivate or inspire you in your personal journey on dealing with a myocardial bridge. Most importantly is to have you leave each episode with hope, knowing you're not alone and that what you're experiencing is real. My guest this episode hails from a state where we've seen many requests for cardiothoracic surgeons. So if you're far south, like Florida, you now have an option. He's an accomplished cardiothoracic surgeon, and as you'll hear in the conversation, no stranger to myocardial bridges. His preference and specialty is minimally invasive cardiac surgery when appropriate. He worked at Columbia Presbyterian and Mount Sinai in New York prior to joining HCA Florida Kendall Hospital and HCA Florida Mercy Hospital, where he is medical director and chief of cardiovascular surgery. As a professor of cardiac surgery, physicians he has trained are all around our country, in Japan and Israel. And that's good news for us with myocardial bridges indeed. He's operated on 6 continents and in 21 countries, has received numerous awards of recognition, and has even been featured on many of the popular talk and morning shows. He has a personal passion for health and wellness, encouraging his patients to make healthy lifestyle choices, and he supports them to do so. He also practices what he expects his patients to do as well. I'm very pleased to introduce Dr. Allan Stewart to our coronary community. Dr. Stewart, welcome to Imperfect Heart.
Thank you. It's an honor to be here.
Hey, we are thrilled to have you here, let me tell you. Let's start with what led you to become a leading cardiac surgeon in the country. You knew at quite an early age you wanted to head in this direction, like 11 years old.
Yes.
How does one manifest from 11 to today?
Well, it's an interesting story. My grandfather was a diesel mechanic. So when I was growing up, he would always teach me how to do brakes and fix a carburetor and work on cars. And he would give me a present for Christmas. And the present was always a tool for my toolbox and then a gift. And unbeknownst to me at the time, the gift was always broken invariably to the point where it almost became a running joke. What I didn't realize, and unfortunately it was much later after he passed away, that he broke the gift and he gave me the tool to fix it. And one year it was a cuckoo clock, and he took the screws out to make the bird come out. And I called him up, I remember, and a month later, and I said, "Pop, I fixed the clock and it works now. And I used that tool that you got me for Christmas to fix it." "Oh, that's a great, what a bizarre coincidence." And I didn't realize that he broke the clock on purpose to teach me how to think critically. And then I watched a Nova episode when I was 11. It was the first pediatric heart transplant. And I was transfixed. And I said, that's what I want to be when I grow up. And just never changed my mind.
Boy, we're happy you were able to get through whatever the schooling was to get you here, because what you're doing is something we're really, really interested in learning a little bit more about. You went from cardiac surgeon to also focusing on the less invasive strategies. Tell us a little bit about that.
Yeah, so I think that what we first want to make sure is that we can do an operation and do it safely. And to the extent that can be accomplished, then we say, well, if it can be safe, can we do it in a way that is less traumatic to the body or cosmetically more acceptable? Because sometimes we're doing these operations on people that are, I remember when I first got started, I was doing an aortic root replacement on a Cosmo model. And she's like, "Please don't cut my chest open." I said, "Well, she's got this big aneurysm. How am I going to do that?" And then I thought about it for a while, and I said, well, I can make this incision underneath her breast implants and then flip them up and then open the chest from there and then put it back down. And we had a plastic surgeon involved and we were able to do it. I said, well, geez, this is interesting. And then we started thinking about, well, are there other people that we can do these type of things in? And sure enough, people appreciate it. But we never, ever sacrifice a cosmetic result for safety.
So not only cosmetic, but healing time on a less invasive procedure is certainly a little more rapid, more often than not less painful.
Right. And so the key is that what we want to make sure of when we're doing minimally invasive surgery, and that's generally we're trying to avoid cutting the chest open or cutting the chest fully open. Sometimes that means we're going to do a partial cut as a inverted T in the chest, or maybe go between the ribs in a small space and not break the ribs, but just separate them with special retractors that we have. And the key in doing that is that we're going to accomplish that uh, doing the same operation as we would do as if we were opening the chest. Because what we don't want to do is sacrifice the quality of the operation for a cosmetically inferior operation. So,
Mhm.
assuming we can get the exact same results with full exposure that we can get through a partial one, we always do the partial.
Not everybody's going to qualify for a thoracotomy or the minimally invasive. And I'm sure sometimes you begin that route, go down that path, and realize this isn't going to work. We need to actually go through a full sternotomy. How do you diagnose or assess initially that the person is likely a candidate for a thoracotomy?
Well, for myocardial bridge specifically, it really depends upon how the heart's rotated. Because if the heart is moved, then most of the left side of the heart, or the area that we're most interested in, which is the LAD, that's the most common site for a bridge. That's running right smack in the side of the chest in this direction, and the heart's when we look on the chest X-ray or a CAT scan and see that the heart's oriented properly, we know pretty well that we can get to the entire distribution of that artery through the side of the chest. If the heart's right up front behind the chest, behind the sternum, well, we're not going to see the whole LAD from the rib space, and then that would be a bad idea because we'd only see the apex of it, and then that leads to the folks who become unhappy with their result because we're not necessarily seeing the whole artery. We might see the area that's seen on the angiogram, that's the area where it looks like the bridge is. But if we can't see the whole artery and unroof the whole artery, it leads to a potential of having an inferior result. So we want to make sure that the key is when we start the incision is that we can unroof that artery from the bottom of the heart all the way to the top.
Now, you're an expert in a variety of different heart procedures, aortic specifically, if I'm not mistaken. What led you to addressing myocardial bridges?
It actually happened by chance because I did in I spent my most of my career in Manhattan at Columbia University, and I was doing a lot of adult congenital surgery, meaning that kids who had birth defects and they had heart surgery when they were babies or infants often would come back later in life either for a heart transplant, which I did, and or some revision of that first operation. Well, one of the things that is common as a congenital problem is what's called an aberrant coronary artery, meaning that one of the coronary arteries, either the left or the right, takes a unnatural course out of the aorta. And I was the head of aortic surgery. And so this unroofing procedure, as it's called, is unroofing it inside the aorta. Well, the patient booked an appointment for an unroofing procedure, but what they really came for was a myocardial bridge.
Ah,
And I said, well, that's not an aberrant artery. I said, it's just, but I was looking at the angiogram and it comes with this like very abrupt U. And then as I heard the story of the patient, they were saying that, well, everybody thinks I'm crazy. I've got 10 catheterizations and 5 MRIs and they come in with a bag of images. And I said, well, I'm at my wits end. I said, well, uh, you know, so geez, I don't even know what you do for this. And so I did some reading and found that what operation the person needs. And I said, well, nobody will help me. And I said, well, I'll help you. I just, I didn't know, then just had a different opinion of why you were here. And so I did it. And the person was so grateful. And then as happened down in Florida, all of a sudden there's an office full of people who have bridges that showed up. And because there weren't a lot of people there to help them. And this was 15 years ago.
yeah. 15 years ago, boy, to think we really haven't made that much progress from 15 years ago to today. although I think we're starting to get some attention now. And I'm glad to hear Columbia is producing the product that you are, because we just had somebody else who had the bridge unroofed at Columbia, as well as a double bypass while they were at it. So, obviously, other complications. Are you working on a beating heart, or do you go on pump?
It depends on the patient, and so the thing is about these operations is that there's really nothing in between the muscle. And the way I describe a myocardial bridge is that it's almost like a python saw itself in a mirror and decides that it's prey. So it wraps itself around it and squeezes. And the only reason that it doesn't die is because the blood flow is cut off to its body, and then it can't squeeze anymore, so it lets loose. And that's sort of the symptoms: is that this little muscle that's circumferential around the artery will squeeze, but then ultimately there's no oxygen to that muscle that's around it, and it lets loose before the person has a heart attack. So they've got all the symptoms in the world of a heart attack, although they don't have one. And so that's what creates the anxiety and the frustration. But there's no separation between that muscle and the artery that's underneath it. So as long as we can get the heart perfectly stabilized, we'll do it off pump. But there are some folks that the artery is almost in the right ventricle, where you're cutting the muscle, and then all of a sudden you're in the inside the heart. Now, if you're on bypass, that's not a big deal. If you're not on bypass, it becomes rapidly a big deal. So, doing it off pump through a mini incision without having the cannulas in you can be upside down very, very quickly. And so it's really a matter of looking at each patient individually. Again, we try and do everything with a minimally invasive approach. We try and do it with the least trauma, meaning stay off the heart-lung machine. But again, we want to make sure that the reason for coming to me is that you want this unroofed. And being on the heart-lung machine for 15 minutes is not a big deal, which is really all it takes. And so to and really it's just kind of seeing with my fingers to cut with a knife over the top of this artery. And the last muscle fiber that's keeping this in place is microscopic in size. And once that cuts, the artery pops up. The worst thing in the world to do is to cut the artery, because now you're into a bypass surgery. Because if the artery is cut and say it's 1.5 or 2 millimeters in its diameter, if it gets cut, we have to sew it. If we sew it, we're going to make it narrow. And now you're creating a stenosis of the artery that didn't exist before. So generally, if you cut the artery in some dramatic fashion, you've got to bypass it, which may have happened at Columbia to that person. So most of the time, people with bridges don't have coronary disease. They just have a bridge. And so we don't want to allow that artery to be injured. So if I find it to be a very deep artery, or it's a long segment that's in the muscle, then we'll just go and bypass for a few minutes, which is very, very well tolerated.
Hmm. As you prepare for diagnosis, what are your requirements to make the decision whether to perform the unroofing procedure for a patient? Do you require a full prerogative testing? What is it that you're looking at to help you make that decision?
You know,
Whether
the
that's
tests,
possible correctly?
they're just not they're not the greatest. There's really no pathognomonic sign on any diagnostic test that's going to say this is the source of your problem, and that's what's frustrating, and that's what leads people to this despair, if you will, because they're told there's nothing wrong with you. Your arteries are completely fine. It's just got a little kink.
It's benign. It's benign. Don't worry about it.
You don't have any coronary disease. There's nothing that can be offered. And they're given nitrates, or they're given beta blockers, and or they're told just don't overdo it with exercise. And that's frustrating to a lot of folks who, I mean, a good number of people that come see me just by nature of being an endurance athlete, come to me because I am. And so maybe I'll have unique appreciations for their plight. And so they said, well, I've been told I can't exercise, or I can't ride my bicycle, or I can't, run a marathon anymore because I've got this bridge. And that's very important to me. So my quality of life is gone. And as a surgeon, our goals are twofold. We want to preserve somebody's life and we want to make it better. And if we can only do one of them, we want to make it better because there's no sense being alive longer if you're miserable. Uh, so, um, so if your quality of life is being limited or impaired, well, then it's the right choice. Typically, the patient has had an angiogram. It shows that they've got no obstruction, but they've got this dramatic turn. They'll usually have either a CT angiogram or a cardiac MRI that clearly shows that there's a bridge, and then there's symptoms. If they're asymptomatic, we do nothing because there's nothing about this that would lead to sudden cardiac death. At least I've not seen that reported. So they've got a normal artery. It's got a bridge. The bridge from time to time will constrict, will cause the symptoms of a heart attack. So the patients have usually had recurrent symptoms, have had one or two visits to an emergency room, has had anatomic testing. I don't really rely on provocative testing because I don't think it's uniformly embraced or reproducible.
What is it that provides you the tool to say, okay, you've got a 3, a 4, a 5 centimeter bridge? What are you using as your best diagnostic to help
Cardiac
identify?
cardiac MRI, I think, is the best test. Although CT scans are getting better and better, the newer CT scans, as well as there's now a generative AI algorithm that's put in at least a 64 slice CT scan called HeartFlow, which can measure the fractional flow reserve in an artery without a cath or without an MRI, and it's done in about 15 seconds. So more and more imaging centers and more hospitals are using HeartFlow as a good means of showing the virtual flow through an artery. So I have had two patients that were diagnosed on HeartFlow scans with a bridge. Now the thing about that, it shows the difference in flow, but it does not show. That doesn't give any anatomy of how deep the bridge is. It'll show the artery and it'll show the kink in the artery, but then you have to rely on the regular CT scan images. What HeartFlow is a 3-dimensional rendering of just the coronary arteries. So you'll see the kink, but you won't see the muscle around it.
Got it. And it's wonderful to hear. I knew it was only a matter of time before AI would be stepping in to really benefit us with this situation because it can do so many things. If we've got X amount of points to identify, it's just going to fill in the blanks, which
Yes.
will make it just that much easier. I'm thrilled to hear that. How many unroofing procedures have you done to date?
Last I looked, it was 75, which is a good number.
It's it's a very
Kind of
good number.
a lot, but it's, for that, it's sort of a rare finding. So I think yeah, it's a bit more now, but that was the last, because I was planning on writing up the experience.
As more surgeons are doing the unroofing procedure, and we are really grateful that this is occurring over the course of even just the last couple of years, we've seen so many more people willing to, I hate to use the word attempt, but in some cases it really is just an attempt. They're not getting the entire artery.
Mhm.
They're missing the a segment. Maybe they thought they had all of it, or there's other roofed arteries that are significant, and they're missing those. What we're learning now is there are procedures that each surgeon does, and their own best practice. And we were talking just a little bit before we came on. If you could share how you go about it,
So,
because I think that's a little different.
which is probably the best way to. This is the artery that's most often involved in the bridge, and this is the so-called LED.
And for the benefit of
Long
those
anterior.
for the benefit of those who are listening, Dr. Stewart is actually showing us a model heart. So the YouTube channel will have the video. Okay.
So this artery here will come down. This supplies blood to the front part of the whole left side of the heart, as well as the area between the so-called septum. And so this is the major artery. Does the lion's share, the yeoman's share work in the heart to supply oxygen and nutrients to it. And you'll see up here where this fat is, there's no muscle up here. So if you get all the way up here on the artery, it can't possibly be involved in the bridge anymore. And this is really up high next to the pulmonary artery. That's where the LED comes out. So the LED comes out. There's what's called the left main coronary artery. That's what comes out of the aorta, and that splits into the artery that goes to the side, the circumflex, making because it's circumferential around the heart. That's why it's named. And then the one that's long in the front, long anterior. Anterior means front. Descending means it goes from top to bottom. So up here, it's this fat. And then the muscle starts about here. So if you get up to here and then unroof it all the way down to the apex, you know there's no bridge because there's no bridge up here. And then if you come all the way down, and sometimes it involves moving this vein over here or even ligating it because it's not that important. But you, at the end of the procedure, want to see that you want to see the artery from up here in this fat pad, and you want to see it all the way down to the apex with no area of obstruction. So if you open it in the front and just cauterize that muscle and move it to the side, and you can see the front of the artery from stem to stern, you know there's no bridge anymore. And because it's charred on either side, it's not growing back. And cardiac muscle doesn't grow back anyway. That's why heart attacks are a lifelong problem because so once you've cut it away and it moves to the side, it can't be circumferential anymore, so it can't cause constriction.
Hmm. I will
Now, the
applaud
problem
you.
with that is that doing it with a robotic case or a mini, sometimes you can't see the whole artery from the top to the bottom, depending upon how the heart's oriented in the chest. And while it's important to people to have a mini, I think it's more important to have a full unroofing.
I applaud you because you are the first doctor in 12, 15 doctors I've spoken with who have given us show and tell. And we actually got to see, the heart as you diagnosed or demonstrated what that artery looks like from top to bottom. So thank you so much for doing that. The other thing that's coming up now just recently is people are talking about scarring.
Mhm.
And you mentioned, well, the heart tissue doesn't really grow back or scar, and then they're thinking that it could even scar over an unroofed artery.
It can't.
How would you address that?
I would say it can't. It's not a possibility as long as the artery is exposed to the front. Now, what could happen is that on occasion the bridge is very deep, or the muscle surrounding what's been cut bleeds. And what some surgeons will do is that in order to stop that bleeding, because uh, it, as I mentioned before we get online, sometimes if the bridge is very deep, you can end up in the heart itself because there's not a lot of muscle tissue between that artery and the free wall of the heart. And sometimes even the artery could end up, the way it's constructed, can end up actually in the heart itself, where in opening the bridge, you can end up in the right side of the heart. That's often just fixed with a stitch, but you have to place it right so you don't constrict the artery. The other is that if there's bleeding, sometimes surgeons will put a little glue over the top to stop the bleeding. The glue can actually cause constriction because the glue is now a shell over the top of the artery. So it's not a wise choice to put any glue or any topical agents that are going to stop the bleeding. You just have to sit there for a little while and let the bleeding stop. But as far as scar tissue forming over the top of the artery, that's not possible.
Okay, that's great to hear because I know a lot of people are talking about it, and it was certainly my understanding post surgery that that wasn't the case either because I asked about that. So I'm glad to hear it, and I'm sure that will allay a lot of the concerns and fears that people have as a result of their surgery, thinking, okay, now I've got symptoms again. Um,
Yeah, I think
before,
there are. I mean, I think with the artery being constricted as it is, there is a possibility of having that artery be a little bit more prone to constriction, or if some stimulants or things that would normally cause spasm of the coronary arteries might be a little bit more. You might be a bit more susceptible to that if you had a bridge, because that arterial tissue is used to being bent, and maybe it's the integrity of the artery is a little bit off that segment. That's something that would be best asked, on someone who's more of a vascular specialist or a basic scientist. But I could see where that could occur, and then maybe that would be treated with some sort of calcium channel blocker to prevent spasm. But as far as scar tissue is concerned, or as far as residual problems down the road, it should not be related to an anatomic bridge. I don't know if the camera on the laptop will be enough to pick this up, but if you look at this, you see
Oh, yeah.
this?
We can hold that close. We can see it.
That
Yes.
is, this is a successful bridge, and you can see there's almost 6 centimeters of the LED in that area in the center. That is the artery, the LED unroofed from the top to the bottom, and that's the result you want to have. That you see, there's nothing on that artery from all the way to the bottom to all the way to the top of it that has any covering at all on it. You can see it's completely exposed, and you can see that big divot of tissue all around it. That's a successful surgery.
Yeah, and that's a nice plump artery there.
Yeah, yeah, yeah. And there were two areas in this patient, one up here and one up here, that were both constricted. So it's important that, when someone says, I have a bridge, to make sure that you're looking at the images yourself as a surgeon and say, well, no, you don't have a bridge, you have a couple.
Mhm.
And you're not, you're not limited to one.
Lucky us, right?
Right.
So, one of the things about the program is while it's intended for the benefit and giving hope to those who are suffering from a bridge and have no clue what's happening and what to do about it as they learn, get more educated, there's an equally important facet of what we're trying to accomplish, and that is to educate the cardiology community, the cardiologists, the cardiac surgeons who still believe these things are benign. And patients present with symptoms, yet they say, "Not that's not that. It can't be that. It's something else." Unfortunately, that's still the prevalence. It's more of that than recognition that this bridge is symptomatic. What would you say to those cardiologists, cardiac surgeons?
Yeah. I think that our traditional teaching is that uh, flow through an artery is normal unless there's a fixed obstruction inside the that you can have extrinsic obstruction. And one of the worst things I've seen are interventional cardiologists will try and put it in these. It doesn't work. And now you've got two problems, because now you've got a stent that doesn't need to be there. And that in and of itself can be a nidus or a focal point to create scar inside of an otherwise normal artery. So stents are being put in a normal artery. Now these stents have no real extrinsic radial force. The radial force is inside of it. So if there's a muscle that's constricting, it's still going to strict it and it's going to bend the stent. And then the person can have a real heart attack, because now you're kinking a piece of metal that's inside the artery, and that can cause clot formation and sudden cardiac death. So you've got somebody who's got a disease that, for all the world, is a nuisance, and it's making people miserable, but it's not going to kill them. And now your treatment has now increased their mortality by putting something, a stent on them that doesn't belong there. So my education to interventional cardiologists is this is not something that should ever be intervened on with percutaneous intervention, and that the population of these folks is enough to realize that the symptoms are reproducible. The symptoms do go away with being with having a definitive surgery. So no, the people are not crazy. They do have an actual problem, and the problem requires a surgical solution. It can't be fixed endovascularly.
Hmm. Well, and thank you to your grandfather for helping you recognize these broken things have tools that remedy them. You know, the other part of what we look at when we're determining on the surgeon that we might have an interest in performing, our unroofing procedure is what are they like? And you guys have a tremendous amount of stress. You are a life and death situation. You hold the most important organ of somebody's body in your hands. How do you relax? What do you do to relieve stress? What's
Uh,
Dr. Stewart do when he gets a few extra minutes?
well, I feel like if you operate on the heart and you believe in, we only have one. We're not our body, but we only get one of them. That we should take care of it. So I 6 days a week do a workout. It's called 54D. It's a muscle confusion hour-long exercise program that I've been doing for a few years. That's one. And then I train in karate with my 13-year-old and 6-year-old boy. So we go and do that 3 times a week. I trained for 12 years as a kid, and my son, who's now 13, found it and dragged me back. And the sensei said, "Well, are you going to train with us?" I said, "No, no, I'm here with my son." And he said, "I heard you used to train." I said, "Yeah, a long time ago." So sure enough, I got roped into it, and I've been doing that for a few months now. In addition, I um, I still love to build things. I built a house as a hobby, and I love to exercise. I do a lot of exercise with my former patients. So I had one guy who kind of wrote me into a marathon when I turned 40, and then a triathlon, and then recently an Ironman, all with
Uh,
people who had surgery. Uh, so
for you.
that's been fun for me. I'm not competitive. I finish, which is how I win. I win by getting a medal. Maybe just a few steps in front of the para athletes, but I finish. But yeah, that's fun for me.
That's amazing. And I think many of the listeners know that I'm a cyclist. Had you done my unroofing, we'd be going out for a ride somewhere at some point in time.
We can do that anyway. You're still a patient.
This is true. This is true. Y- How would an interested party get hold of you? What's the best way to get in touch with you at the
Yeah. So
hospital?
what I normally give people, especially those who are calling from a distance, is that I just give them my cell phone because it's rather than try and get through, it's become increasingly difficult to get in touch with a doctor through a normal means. So and you could put it down on on your
Show
site.
notes.
It's 917-748-7836. It's my New York number. I've kept it since I moved to Miami, and but I'm available to either leave a voice message or a text message, and I always answer within by the end of the workday.
Thank you for that. Very, very much appreciated. I'm happy to say that now, if you're living in the South, we have some really credible resources for our listeners to explore with Georgia, Texas, and now Florida surgeons to speak with. And that's really exciting for us to know that there's a greater recognition and there's a greater competence that we can now rely on for the symptoms. Yeah, so Dr. Stewart, thank you so much for your time. I really appreciate you doing this for us. Your insight, knowledge, experience, it's more so for the training that you're providing into the world with the doctors that you've released through your program and taught, who we now know will accept us as we reach out to them, and they won't think we're crazy. Uh, but your story, it really brings comfort to the people in need of getting to that next step. And you shared some things today that we've not heard from other surgeons, as everybody has a little bit different nuance, and I think extremely helpful, especially the demonstration of the heart model. That is a really big piece, and I'm going to encourage everybody to look at that on the YouTube channel.
There's one thing I would say is that people are much more willing to travel to a restaurant than they are to travel to a church or a doctor. You generally go to your local church or you go to your local physician, and but there are some operations that require you to get on an airplane, and like this is one of them. Is that you don't want to have somebody who has not done this before taking a knife to a muscle fiber right above your artery, because what happens then is you have this surgery, and uh, doctors who are not skilled or not experienced with a particular type of surgery will err on the side of caution, meaning that they might not do the complete surgery. They might, open up the artery, but if you don't open the muscle all the way down to the artery, you haven't fixed the problem, because even one muscle fiber over the artery is still a bridge. It's maybe less tight, but it's still there, and it's still going to constrict. You're still going to have symptoms. So unless it's completely unroofed, like the picture I showed you, it's not done. And and it's important, whether you come to South Florida or any of the other centers of excellence that do this. Your hospital stay is about 3 days, and 2 days later you can get on a plane and go back home. So it's not like you'd have to be planning on being in a particular place for weeks on end, or incurring a massive expense. Most hospitals like ours have rates with hotels right in the area. Although July and August are not ideal times to go to Miami, the rest of the year is. There are worse places in the world to be than South Florida in the winter. But I think that for routine cardiac surgery, yeah, there are plenty of good places locally in almost all states. But for nuance operations, it's important to find your surgeon, be comfortable with that person, and realize that it's not the worst thing in the world to come in, have surgery, and go back home.
Mhm. And I think that's a great point. I'm glad you brought that up because it is about being comfortable with the surgeon. You may find somebody who says, "Yeah, I can do this," and you say, "Well, how many times have you done it?" And they go, "A couple. I'm familiar." I'm not sure that's the person I
Yeah,
really
no,
want.
it's because the worst thing in the world to end up is that you have a normal artery and now you've got a bypass, or now you've got a stent, or now you've got some sort of or an incomplete fix.
Yes.
Because that's actually a catastrophe. Because if you have the surgery and the unroofing wasn't complete, you're not going to be told that necessarily, or the surgeon might think it was complete, but it wasn't. And now you've got all these symptoms. You've gone through an operation, and now to do that as a redo is a much bigger deal, because now you have to just cut through scar tissue and then get to the artery, and all the visible planes aren't there. So to have a bad operation for this is probably worse than having no operation.
No. Well, thank you for that too, because we have seen that now a couple of times where they said didn't get the entire roof portion of the artery or missed a part of it. And we've even had a situation where somebody went in and said, nah, a little more complex than I want to do, and closed them back up. So,
Yeah, it's worse than doing nothing.
correct, correct. Well, Dr. Stewart, thank you from the bottom of my imperfect heart for your participation on the program. And, best of luck to you as you continue doing what you do for us. Thank you.
Thank you.
Thank you for listening to Imperfect Heart. It's my hope that this information helped in some way to improve your situation or will help you better understand this condition. More importantly, that it gives you hope through stories that there is help and you most certainly are not alone. If you've been diagnosed with a myocardial bridge, please be sure to join the private Facebook group, Myocardial Bridge Support Group. For more information about our program or to reach me directly, visit the website, myimperfectheart.com. If you like what you heard today, please give a positive review, thumbs up, high five, or whatever your app likes. And be sure to share with everyone important to you so they understand what it is you're dealing with. Please subscribe as well. Welcome each day with gratitude and positivity. The views and opinions expressed in this program are solely those of the host and the guest and are not intended to provide, nor are they a suitable substitute for, professional care by a doctor, therapist, mental health professional, or other qualified medical professional. Imperfect Heart is a production of Hear Me Now Studio.